Все готово. Good morning, student. The topic of our lectures is chronic cholecystitis and cholelithiasis and chronic pancreatitis. Chronic cholecystitis. You remember of the organs of the biliary system. It is gallbladder, it is bile duct, it is cystic duct, common bile duct, and sphincter odi. And you remember topography of the biliary system in abdominal cavity, because it is very important where is locates of these organs and where we can determine different change. Chronic cholecystitis. Chronic cholecystitis is chronic inflammation of the gallbladder, which is combined with the dyskinesia of the gallbladder and sphincter apparatus, and violation of biochemical characteristic bile. Etiology of the chronic cholecystitis. Very often it is bacterial cholecystitis. Bacteria can enter the gallbladder, hematogenosis, lymphatic, or ascending from the duodenal, and maybe viral cholecystitis. And very often we can see inflammation in the gallbladder if the patient has acute hepatitis A, B, C, D, and other. Maybe parasitic cholecystitis, and maybe other autoimmune. It is very rare, and also maybe enzymatic cholecystitis. This variant is developed for the admission of the pancreatic juice into the gallbladder, and then inflammation because of the gallbladder. Chronic cholecystitis divide without stone and calculose. The degree severity of the cholecystitis may be easy, moderate, heavy. Stage of the diseases may be remission, fading aggravation, and aggravation. And also this patient may have different dyskinesia present, and maybe present dyskinesia or not present. If there are complication, non-complication, and complication. Clinical features of this chronic cholecystitis. The first, it is main complaints if the pain syndrome. Pain localization in right hypochondrial, and pain occurs in violation of diet, fried and fatty food, alcohol, and other, emotional stress. And this pain very often radiate in right shoulder, right side of the neck and of the back. And character pain depend on the type dyskinesia of the biliary system. When the patient has hypotonic dyskinesia, observed a dull arching pain. If the patient has hypertonic, usually acute and paroxysmal pain. And this patient may have dyspeptic syndrome. It is bediness, nausea, feeling of the heaviness in epigastric, unstable stool, and flatulence. And if the patient has inflammation, usually increase temperature, but temperature usually subfebrile temperature. This syndrome autonomic dysfunction is determined most patient, increase fatigue, irritability, sweat, headache, tachycardia, and other symptoms we can determine this patient. Symptom, if we do physical examination and do palpation of the abdomen, we can see many symptoms. The first symptom connected with the compression of the gallbladder. The first symptom, it is scary symptom. When pressed on the point in gallbladder, pain on the inspiration increase in this point. And Murphy's signs. When pressed on the point of the gallbladder, cannot breathe because the severe pain. Next group symptom, it is shake symptom of the gallbladder. It is Leppen symptom, pain on the percussion then of gallbladder. Vasilenko symptom, pain of the percussion that the gallbladder on the inspiration. And Ortner symptom, pain on the percussion on right costal arch. And we can palpate in gallbladder and point in the gallbladder. Point of bladder is the costal arch and external muscle, rectum muscle. And there are many pain points. The point of the gallbladder, it is rectum muscle and costal arch. Haledeha pancreas point. This point, outer edge of the right rectum muscle at 5 centimeters about the umbilicus. And phrenicus symptom, when we determine the pain in phrenicus nerves on the neck. It is where is this point? It is point of the gallbladder. It is pancreatic point. It is then it is where we can determine phrenicus symptom, and we can determine other point. It is acromial process and point, and when we do press on this point, the patient may have increase and feel pain. And angle of the scapula and angle of the scapula, and paravertebral point at 8 and 9 thoracic vertebra, and there are increased sensitivity in arise. For the diagnosis of the chronic cholecystits, use general blood analysis, and if we do this analysis, we can determine increase leukocytes and shift to the left neutrophils and increase ESA. And if we do biochemical examination, we can determine increase alkaline phosphatase. And if increase alkaline phosphatase, usually this patient has inflammation in gallbladder and bile duct and cholangitis. And if the patient has chronic inflammation, we can see increase beta and gamma globulins in the blood. And if we do duodenal intubation, reveals. We can, in the portion B, we can determine many leukocytes, present bacteria, protozoa, and if we do this method examination, we can determine variant of the dyskinesia gallbladder in this patient. And also we can do other instrumental method examination, and now we can very often do ultrasound examination and the X-ray study of the gallbladder. Ultrasound signs of the inflammation of the gallbladder. It is increased gallbladder wall more than 4 millimeter, and compaction. And this Murphy's positive symptom, pain with a pressure ultrasonic sensor, increase and deformation of the gallbladder, present stone in the gallbladder, and we can determine a variant of the dyskinesia. In this we can see stone in gallbladder, we can see stone in cystic duct, bile duct stone, and also ultrasound examination, and we can determine size of the gallbladder and presence of absent stone. X-ray, signs of the examination in the gallbladder. It is reducing of the concentration of the gallbladder function. It is changing of the contractility of the gallbladder, change in the form and size of the gallbladder and cystic duct, present stone, and also we can determine a variant of the dyskinesia of the gallbladder. In this X-ray examination we can see deformation of the gallbladder. And very rare we can use endoscopy retrograde cholangiopancreatography, and if we can determine where is the stone, because the stone may be in a different part of the biliary system, and if we do this method we can determine where is this stone. And also we can determine computer tomography and radioisotopic region method, and cholecystography. Treatment of the chronic cholecystits in acute phase. It is diet number 5. When hypertonic dyskinesia, frequent small feeding 4 to 5 times a day. Limit food that cause gallbladder contraction. This fat, meat products, vegetable oil, beer, soft drink, drinking mineral water with the low to the medium mineralization. If the patient has hypotonic dyskinesia, we can use products with the choleretic section. It is butter and vegetable oil, cream, black bread, vegetables, mineral water with a high degree of the mineralization. And we can use many drugs therapy. It is antibacterial therapy. It is different antibiotics affecting coliform microorganism. It is antibacterial fluoroquinolones. It is sulfonamides, nitrofurans, and metronidazole. elevated temperature and severe pain, I use intramuscular and intravenous antibiotics. Next, it is anti-inflammatory therapy. It is baralgin, ibuprofen, and antioxidants drugs. And very often we can use choleretics. It is a preparation containing bile or bile acid. It is alcohol, liabil, halagon, and other. It is synthetic drugs and herbal preparation. If the patient has dyskinesia of the gallbladder, type dyskinesia of the hypotonic, we use cholekinetics. It is magnesium sulfate, different oils, sorbitol, xylitol, and halasas, and other drugs. And then we can use drugs affecting the motor function of the gastrointestinal tract. It is anti-cholinergic drugs. It is atropine, metazine, platifilin. It is nitrates. It is non-calcium channel blocks. It is antispasmoidics and prokinetics. And if the patient has inflammation, we can use detoxification therapy. It is we can use different solution intravenous. In severe cases, we can use hepatoprotectors if the patient has inflammation in the liver. And treatment of the complication and comorbidness. In case of the hypofunction of the gallbladder, we use a blind tubage for the fraction of the bile tract, stimulation of the bile secretion, and contraction of the gallbladder. Blind tubage method. In the morning on the empty stomach, drink 1 or 2 glasses of mineral water, or we can use magnesium sulfate, sorbitol, xylitol, different oil. Then the patient lies on his right side with a hot water bottle for the 1 or 2 hours. A positive result is act of defecation, greenish feces, indicating and the admissions of bile. Gallstone diseases. This is diseases which associated with the formation of stone in gallbladder or bile duct, as well as positive violation of ductal patents due to blockage stone. The etiology of the gallstone is not well known. Description of gallstone in children, even the first mouth. In 30% of the patient after 70 years on the autopsy reveal gallstone. So the formation of stone is not always combined with the metabolic disorder of cholesterol. Now we can know only some exogenous and endogenous factors that increase the likelihood of stone formation. It is age of over 40 years. Female gender, genetic factor, a diet low the fiber and high fat, obesity, pregnancy. Also it is hyperlipidemia, the loss of bile acid, it may be diabetic mellitus, dyskinesia of the gallbladder and inflammation, prolonged fatis, total parenteral nutrition, and many other factors. There are 5 types of the stone chemical composition. It is cholesterol stone, it is pigment stone, it is calcareous stone, phosphate stone, and mixed. Very often we can see mixed stone and different variant composition. It is a different composition and size of the stone. Clinical features of the cholelithiasis. 2/3 of the cases are asymptomatic gallstone flow. Risk of the biliary colic during the year in this patient is 1 to 4%. And the patient with the asymptomatic gallstone really develop complication. The main syndrome and symptom of the biliary colic. It is pain syndrome. Syndrome biliary colic occurs when the stone passing through the bile duct. Duration of pain in biliary colic depends on the stone diameter, its location, and rate of passage to the biliary tract. Usually pain in right hypochondrium, radiating to the right clavicle, right hand and in the back, right shoulder. And also maybe identical symptom of the chronic or acute cholecystits without the stone. Maybe in this patient, maybe syndrome, it is obstructive jaundice, and we can see yellowness of the skin, dark urine, and discolored feces. And also this patient may have dyspeptic syndrome. It is nausea and vomiting. In vomit, bile, maybe bile, feeling the bitterness in the mouth. And this patient may have cholelithiasis syndrome. In a case prolonged pain and obstructive jaundice develops itching skin. And the patient has increased bile acid in the blood, and the patient may have cholelithiasis syndrome. With the occlusion of the cystic duct, arises inflammation, edema, and the gallbladder, and then develop of syndrome of peritoneal irritation. When obstruction of the common bile duct may be formed inflammation in bile duct and liver, and this patient may have cholangitis and cholangiohepatitis. When obstruction of the common bile duct and sphincter vodi, this patient may have acute pancreatitis. This is due to reflux of bile into the pancreatic duct and then activity of the enzyme. It connects with the structure of the sphincter odi, because sphincter odi may be different structure. It is one variant, other variant, and third variant of the sphincter odi. Symptom, what we can determine, it is identical of the chronic cholecystitis. It is symptom of the compression of the gallbladder, and it is symptom shake of the gallbladder and pain point. Diagnosis of the cholelithiasis. The stone in biliary system are determined if we do ultrasound method examination and X-ray method examination and computer tomography. With obstructive jaundice and unknown genesis, we can use endoscopy retrograde cholangiopancreatography. This is a very important method, and also we can do Billy scintigraphy and laparoscopic cholangiography. It is ultrasound examination, and we can see stone in the gallbladder. It is also stone in the gallbladder. It is stone in bile duct. It is normal gallbladder. This situation when the patient do examination of the stomach, and near the stomach we can see many stone, and patient has pain in epigastric region, and doctor do examination, X-ray examination of the stomach. But near the stomach we can see many stone in gallbladder, and all gallbladder include of the stone. And also we can use computer tomography and then determine present or absent stone in the gallbladder. Or endoscopy retrograde cholangiopancreatography. Where is the stone? Because if the patient has very small stone in the bile duct, on the ultrasound examination and X-ray examination we cannot determine where is. If we do this method, we can determine where this block of the bile, and determine what is the cause of this obstructive jaundice. Or Billy scintigraphy, method of determine the function states in the biliary system. The time spent isotope in the liver, gallbladder, and the duodenum. Laboratory test. If we do examination of the blood, we can see also increased leukocytes with the shift to the left, and increases SAR. If we do biochemical examination, we can determine obstructive jaundice. It is increased bilirubin, direct and indirect, increase total bilirubin and direct bilirubin. And maybe increase alkaline phosphatase and glutamine transpeptidase. And hypocholesterolemia and cholemia if the patient has cholestasis syndrome. Treatment of the gallbladder. It is non-surgical, and surgical. Non-surgical, it is drugs dissolution of the gallbladder. Then other method, it is extra corporal shock valve lithotripsy and laser damaged stone. And surgical, it is a laparoscopic cholecystostomy of this patient. Indication for the conservative treatment of the cholelithiasis. Asymptomatic cholelithiasis. Effect of biliary colic are very rare. There are contraindication for the surgery. The presence of poor cholesterol stone, functioning gallstone. If the patient has a stone with diameter not more than 2 centimeters and found gallstone no more than 2 or 3 years ago. Contraindication of the conservative treatment of the cholelithiasis. Non-function of the gallbladder due to cystic duct or obstruction. The presence of a large stone more than 2 centimeters. And if the patient has mixed stone, it is patient has different variant jaundice. It is obstructive jaundice, parenchymal jaundice, or hemolytic jaundice. If the patient has failure of the liver and elevated transaminase. Also, if the patient has kidney damage, it is a sign of the gastrointestinal diseases, diarrhea, present enterocolitis, and pregnancy. Scheme of the conservative treatment of the cholelithiasis. We use ursodesoxycholic and henodesoxycholic acid many times. And we can use this treatment near the 2 years, but we must study this treatment through the 2 months. And if the size of the stone decrease, we can you can use continue this method. If don't change the stone, the size of the stone, you must stop this treatment. This also we can use combination drugs. It is litofalc. It is contain ursa and henodesoxycholic acid in these drugs. And also there are other drugs. It is alimetin, it is liabil, phenobarbital, zixarin, and herbal preparation. And then we can use how change the size of the stone in gallbladder. If the patient has absent asymptomatic on this patient. Extracorporeal shock wave lithotripsy. Indication: attack of the biliary colic in history. Stone in diameter up to 3 centimeters. Visualization of the gallbladder by oral cholecystography. Indication of gallstone by ultrasound and X-ray. It is a method of the lithotripsy in the patient. It is apparatus for the lithotripsy also. It is a laser fragmentation of the gallstone. Some features. The method we can use only in 15% of the patient. Complication of the extracorporeal lithotripsy. the possibility of jaundice due to the blockade of the biliary tract, stone the fragments. Possibility the pancreatitis, and the patient may have inflammation in pancreas. And the main damage of this method, high recurrence of the gallstone after 5 years, recurrence in 20 to 50%. Chronic pancreatitis. Chronic pancreatitis is inflammatory of the pancreas diseases with the development of the parenchyma sclerosis, duct damage, and change in exocrine and endocrine function of these organs. The causes of the chronic pancreatitis. The first, very often, it is alcohol. It is also maybe diseases of the stomach, duodenal, gallbladder, and pathology of the biliary tract, with the hypotension in the bile duct, or the bile reflux into the duct of the pancreas, and then activity of the enzyme. Also, it may be infection, transition of the infection from the bile duct to the pancreas by the vessels of the lymphatic system. Also, the chronic pancreatitis, maybe if the patient many times use different medical, it is medicine, it is sulfonamides, antibiotics, glucocorticoids, and other drugs. Also, the patient may have autoimmune disorder and chronic pancreatitis, and congenital disorder of the pancreas, and heredity. In the progressive of the chronic pancreatitis are playing importance pathology change in other organs of the digestive system. And very often it is pathology of the biliary system, pathology of the duodenal, and pathology of the stomach. The main symptom of the exacerbation of the chronic pancreatitis, attacks of the pain in epigastric region, associated or not with the male. Pain radiating the back, neck, left shoulder, but it is very, very rare. And you must remember that inflammation in head, pain in right hypochondrium. If the patient has inflammation in head, head pancreas, pain in right hypochondrium. If the patient has inflammation in body, pain in epigastric probe, and if the patient has inflammation in if the patient has tail, in this situation, pain in left hypochondrium. If the patient in all pancreas, in this situation, this pain may be very often irradiating the lumbar region. And you must remember that pain does not subside after vomiting, and the pain increase after hot water bottle. Also, this patient may have dyspeptic syndrome, and this patient may have nausea, vomiting, and flatulence. And very important syndrome, it is malabsorption syndrome. But malabsorption syndrome, the patient with chronic pancreatitis, maybe in 50% of the patient. And if the patient has this syndrome, this patient may have diarrhea and feces unformed, and in feces steatorrhea, amylarrhea, creatorrhea, and weight loss. On examination patient, we can see signs hypovitaminosis if the patient has malabsorption syndrome, and hemorrhagic syndrome. This symptom of the gray tonus. It is subcutaneous hemorrhage and cyanosis on the lateral surface of abdomen or around of the navel. But this hemorrhagic syndrome, maybe if the patient has acute pancreatitis. In chronic, usually absent this syndrome. Very important, it is malabsorption syndrome. Then we can think about the pathology of the pancreas, because pain in chronic pancreatitis may be in different part of the abdomen wall. In right hypochondrium, in epigastric probe, in left hypochondrium. And in the beginning, very difficult to determine. It is pathology of the pancreas. And if we do physical examination, it is Cholelithiasis pancreatic point, Kacha point, and a point in between the outer and middle third of the left costal arch, point of the left phrenic nerve, and point in the left ange vertebral. But this point may be connected with the other pathology. If the patient has chronic cholecystits, also this patient may have pain in Cholelithiasis pancreas point. Kacha point, if the patient has pathology of the intestine, also if I press in this point, also the patient may have pain. And other point. And because if we do physical examination, very difficult to determine it is pathology of the pancreas. Symptom, Voskresensky symptom. It is pulsating aorta is not palpable, with a reduction of the pancreatic edema after treatment. Aortic pulsation is again palpable. And if we do auscultation of abdominal aorta, we can hear a murmur in abdominal aorta. But these signs, maybe if the patient has atherosclerosis or aneurysm abdominal aorta, also we can hear a murmur in abdominal aorta. Well, if we do laboratory diagnostic of the chronic pancreatitis, in the blood we can determine also change in the leukocytes, increase leukocytes and shift to the left and increases. But if the patient has chronic, in common blood analysis, we cannot see this change. Biochemical analysis in the blood, we can determine increase amylase, lipase, and trypsin, and increase urine amylase. And if the patient has many time chronic pancreatitis, and this patient may have increase in endocrine function of the pancreas and hypoglycemia. We can determine hypoglycemia in this patient. If we want to determine excretion, exocrine function of the pancreas, we can study of the pancreatic elastase in the feces. Normal is 200 to 500. If decrease pancreatic elastase, it is signs of the degree exocrine insufficiency. And if we do feces, we can determine creatinine, steatorrhea, and amyloria without signs of the inflammation, absent leukocytes, absent other signs what to do of the pathology of intestine. And very important, it is instrumental method of the research. It is ultrasound and computer tomography. If we do ultrasound examination, we can determine how change the size of the pancreas, and also pancreas we can see on the computer tomography. If we do ultrasound examination, the normal size head, it is near the 3 centimeter. The body near the 23 millimeter, and tail near the 15 millimeter. And very important we can method examination is endoscopy retrograde cholangiopancreatography, and then we can study structure of the parenchyma of the pancreas, and how change the pancreatic duct. And if we cannot determine, we can do abdominal laparoscopy, and then also we can determine chronic pancreatitis. Treatment of the chronic pancreatitis. Before arrival of the doctor, you must follow 3 rules. It is hunger, it is cold, and rest. Painful symptom can be reduced by the eyes back to the abdomen, 3 days of fasting, and during this period drink mineral alkaline water without gas. You must use diet number 5 during the exacerbation. The intake of fatty and fried food is reduced, alcohol ban, reduction of the acidity of gastric juice. It is we can use a blockage of the histamine H2 receptor, and a blockage of the proton pump, or antacid preparation. Management of the pain syndrome. It is analgesics, but you cannot use morphine, because morphine do spasm of the sphincter odi. And with the spasm of sphincter odi, you can use different spasmolytics. In severe pain, we can use tramadol parenterally. And we must decrease synthesis of the enzyme in the pancreas. It is somatostatin when decrease enzyme, and anti-enzymatic therapy. It is Cantrical and Gardox. Normalization of motility of the duodenal and gallbladder. It is prokinetics and anti-edema therapy if the patient has edema of the pancreas. In this situation, we must use diuretics, furosemide, hypotiazide in this patient. And also, if the patient has inflammation and it may be inflammation connect with the bacteria, and we can use antibacterial therapy, different antibiotics. And if the patient has decreased exocrine function of the pancreas, and if we can see malabsorption syndrome, we can use enzyme therapy with reduced inflammation. It is there are many different drugs. It is creon, pancreatin, mesimforte, fistal, and other. And if the patient has malabsorption syndrome, usually this patient has hypovitaminosis, and in this situation we can use different vitamins. It is A, D, E, K, and group B. That's all.